Hello everyone, good evening. Welcome to another important session, that is syndromes in surgery. So we are going to have this topic in parts. So this is part 1. So let's see what are all the different syndromes which are important in surgery. First one, Algr syndrome, which is also called AAA syndrome. Why is it called AAA syndrome? Means because you have three important things which start with letter A. So one is your alacremia. Because of the deficiency in lacrimal glands, there will be decreased lacrimation. That is why there will be alacremia. A means absent, lacrimia means tears. So there will be dry eyes. Second one is achalasia. You know that basically in lower end of esophagus, normally whenever food comes, your lower end of esophageal lower esophageal sphincter should relax so that the food will pass down into the stomach. But in achalasia cardia, here in LES, there is decreased nitric oxide ergic organs. Sorry, nitric oxide releasing neurons. That is why there will be failure of relaxation of this lower esophageal sphincter that will cause achalasia cardia. And the last one is familial adrenal insufficiency. So there will be decreased adrenal hormones in case of familial adrenal insufficiency. This is about Algr syndrome. Second one, Beckett-Bettaman syndrome. Again, it is something like part of your pediatric surgery, etc. You know that. Just remember here, few things are enlarged, few things are deficient. So what are deficient and what are enlarged? Let's say, for example, usually you are having hyperinsulinemia. So because of the increased insulin, baby frequently gets hypoglycemia. So there will be neonatal hypoglycemia. Then many of the parts in the body will be enlarged. Let's say, for example, your tongue is enlarged, that is called macroglossia. Half of the body is enlarged, that is called hemihypertrophy. And there is a defect in the umbilical region where your bowel is herniating outside. So that is called your omphalocele. Then there are certain important tumors, embryonal tumors, which are associated with your Beckett-Wiedemann syndrome. So one is your Wilms tumor, hepatoblastoma, neuroblastoma, rhabdomyosarcoma. And you know, Wilms tumor is nothing but your basically it's a tumor within the kidney. So it is just a diagram showing where you are having Beckwith-Wiedemann syndrome features. So there will be mild microcephaly. This is the one that will be little bit small in size, and rest of the things usually in the body are enlarged. So you have large prominent eyes. There will be tongue enlarged, which is called macroglossia, and there will be omphalocele, which is also called exomphalos. And the other thing is there will be cryptorchidism associated, and you know there will be half of the body which will be like enlarged. So half of the body will be enlarged. That is called hemihypertrophy. And the baby frequently goes into neonatal hypoglycemia because of the increased insulin. So hyperinsulinemia. Next one. There is something called blind loop syndrome. There are many areas where you can have this blind loop syndrome. So it is also called bacterial overgrowth syndrome. Let's say, for example, if this is your small bowel loop and there is some diverticulum or something like that. So let's say, for example, if the direction of the diverticulum is such that the food enters into this diverticulum and part of the food will be accumulated here. That is why there will be deficiency of certain things in case of this scenario. Whereas, let's say, for example, if the diverticulum is such that even though something is going inside, but it is draining into the distal segment, in such case, there will not be deficiency. There will not be deficiency. Now, this is something called where you are after Billroth operation, especially Billroth 2 operation. So, this is called afferent limb. This is called efferent limb. So, let's say, for example, here, your bacterial overgrowth has occurred, and normally your bile should come here from the common bile duct along with your main pancreatic duct. It is opening into the second part of duodenum. Normally, bile should come here like this, but because of the bacterial overgrowth, this peristalsis of this limb has been decreased. So, in such case, this is called afferent loop syndrome. This is afferent loop syndrome. Now, let's say, for example, a loop of your jejunum has got multiple diverticulae, And you know that jejunum is the most important site of absorption. And wherever you are having this food accumulated here, again, there can be a chance of secondary infection here, and it can undergo even perforation also, right? So let's say, for example, you have a stricture within the terminal ileum or some part of ileum usually. So wherever you are having ileal stricture, the distal part of that segment of the bowel will get dilated. So again, because of the stricture, there will be stasis and there will be increased bacterial overgrowth. Okay, yes. And this is something like, let's say, for example, this is called stenosis anastomosis syndrome. So, nothing but, let's say, for example, you have done enteroenterostomy. This is called entero. One part of the bowel is anastomosis to another part of the bowel. So, in case of enteroenterostomy, there can be anastomotic stricture. Okay, so whenever there is anastomotic stricture, again it can cause bacterial overgrowth in this part of the bowel. So in such scenario, this will be the blind loop. Okay, and the other thing is another example where you can have is that, let's say for example, this is your appendix, terminal ileum, cecum, and this is your ascending colon, transverse colon, etc. Let's say for example, you have got some obstruction within the transverse colon. Normally, your ileocecal valve is a one-way valve, so it will not allow any retrograde flow of the content. Let's say, for example, in a disease process where your ileocecal valve has been incompetent. So, whenever you have got incompetent ileocecal valve, so in such scenario where you have got ileocecal valve is abnormal, so what happens? Your content can go back. Okay, so that is abnormal. Patient will be having feculent vomitings and all. But if IC valve is normal, whenever IC valve is normal, in such case, already there is obstruction within the transverse colon and ileocecal valve is normal. So it is only a one-way valve. In such case, this part of the bowel can become the blind loop. So this is another scenario that has been explained here. So this is called blind loop syndrome. Next one, Bowerhouse syndrome. You know that usually esophageal perforation can happen. So usually whenever esophageal perforation happens in the lower end of esophagus, it is most common on left side. So whenever there is esophageal perforation at the lower end of esophagus, there can be certain group of clinical features. So what are they? Usually because of the uh, abnormal peristalsis or antiperistalsis, you can have vomiting. Second one, as the intraesophageal contents is leaking into the mediastinum, there can be chest pain. And you know that basically it has got air also. So part of the air can be there within this subcutaneous space. This air can get escaped into the subcutaneous space and it can cause subcutaneous emphysema. And you know that these three features are together called Mackler's triad. Mackler's triad. Okay, so you can remember the clinical features of Bowerhouse syndrome if you want a mnemonic. So M for mouth flow, or so that is nothing but your vomiting. So air for A for air, so nothing but your subcutaneous emphysema. Then C for chest pain. Okay, so this is about Bowerhouse syndrome. Now coming to the next one, Bowerett syndrome. So let's say, for example, a patient has got a cholelithiasis. In a chronic, in the long run, what can happen is that if the stone is very much large size, this can undergo perforation within the gallbladder. So it can have perforation. That is one fate. The other thing is, if the fundus of the gallbladder is coming and having pressure on the duodenum, so it can have fistula between your gallbladder and small bowel. In such case, if the stone escapes from gallbladder into the small bowel, at some part of the small bowel, it can cause obstruction. So this is called your gallstone ileus. Okay. Then let's say, for example, if the fundus or the body of the gallbladder has formed a fistula, which especially this first part of the duodenum. In such case, so you know that you have got a pylorus here. This is your D1. So if the gallbladder is having a fistula between D1 and gallbladder, so what happen? Your stone will go and sit at the level of around somewhere distal to just distal to your pylorus. So in such case, it can cause gastric outlet obstruction. So what is Bowred syndrome means? It is nothing but gastric outlet obstruction which is caused by impacted gallstone in pylorus or the proximal duodenum. So pylorus or proximal duodenum. This is called Bowred syndrome, right? Next one, very important one, Butar syndrome. So you know that basically your liver has got a venous drainage in the form of hepatic veins, right hepatic vein, middle hepatic vein, and left hepatic vein, which will be draining into your IVC. So let's say, for example, whenever you have got some obstruction within the hepatic vein or even in IVC also. So whenever there is hepatic vein occlusion or IVC obstruction because of either thrombosis or it can be in the form of either web. So it can be in the form of thrombus or IVC web. So in such case, there can be this syndrome happening that is called Butar syndrome, where normally you know that liver has to be, so there will be portal vein will be here, so there will be contents coming to the liver and draining into the IVC. So whenever there is hepatic vein thrombosis or IVC obstruction, what happens? There will be obviously hepatomegaly. So one is hepatomegaly. Then the other thing is because of the liver dysfunction, so there can be fluid within the peritoneal cavity, that is nothing but your ascites. And also there will be pain abdomen. So these are the three important clinical features you have got. Okay, so abdominal pain, hepatomegaly, and ascites. So these are the three important clinical features for your Butar syndrome. Next, coming to the very important one, Carcinoid syndrome. So you know that normally it can happen anywhere in the body, and let's say for example it is your gut. So whenever you have got gut carcinoid, you know that your bowel will be draining into uh, this portal vein. So this portal vein normally at liver your 5-hydroxytryptamine, that is nothing but your serotonin, is metabolized. Okay, so let's say for example this, wherever you have got carcinoid syndrome, this can give metastasis within the liver. So these metastases will secrete 5-hydroxytryptamine, which can go into your IVC. Okay. So whenever you have got a 5-hydroxytryptamine, which is going into the IVC, that means it is entering into the circulation. So in such case, it can cause symptoms. Okay. Otherwise, you have got, let's say for example, you have got bronchial bronchus carcinoid. Okay, or as we have discussed here, it can be in the form of mainly midgut. Okay, mainly midgut. So in such case also it can cause carcinoid syndrome. So what will be the predominant symptoms? Basically because of the increased 5-HT, because of the increased 5-HT, there can be, usually most common will be pain abdomen, or there can be flushing, there can be diarrhea, and also there can be main important thing, especially when it goes to bronchus. So your bronchus can have spasm. So bronchospasm. Because of the bronchospasm, when you auscultate the chest, it will cause wheeze. Okay, so these are the important clinical features in case of carcinoid syndrome. Okay, right, moving to the next one, Chart syndrome. Again, it's an important pediatric condition, or you can have this. So mainly it is a acronym. So you need to remember the expansion. So you know that there will be coloboma of the iris. Then there will be heart defects. Okay. So you can remember. So you will be having heart defects and iris defect. Then you have got choanal atresia. Choanal atresia. Then there will be growth retardation. So there will be overall growth retardation. Then there can be genitourinary anomalies. Then you have got ear abnormalities. Okay. So this is something about Chart syndrome. Now coming to next one, Chilaiditi syndrome. It is one of your differential diagnosis for pneumoperitoneum, or when you have air below the right dome of the diaphragm. Okay, so what happens in Chilaiditi syndrome? In few individuals, there will be interposition of your large bowel, especially this hepatic flexure or even transverse colon, can go very higher up. So this is your diaphragm. This white line is your diaphragm. So below the level of diaphragm, you have got air here. So it is nothing but your enlarged large bowel or normal large bowel. So whenever you have asymptomatic interposition of large bowel between the liver and the diaphragm, that syndrome is called Chilaiditi syndrome. Okay, so it is one of your differential diagnosis for your pneumoperitoneum or air below the right dome of diaphragm. Right. Next one, compartment syndrome. So again, it happens usually in case of trauma or in case of very severe cellulitis, etc. So usually most commonly after trauma. Now you need to remember there are 6 P's. So the patient will be coming with certain symptoms. So on examination, there will be certain clinical features. So you can remember the features like this. So there will be pain out of proportion to injury, especially with the passive movement of the affected compartment muscles. Then there will be paresthesia and there can be paralysis. And just by looking at the limb, you can say there will be decreased color, like there will be pallor. Classical pallor will be there. And when you just palpate it, so again you can divide it into like inspection and there will be palpation. So this is how you can remember the things systematically, right? So poikilodermia, there will be cold limb because of the decreased blood supply. There can be cold limb. Then when you palpate pulses, distal pulses, there can be decreased or even absent pulses. Okay, so that is pulselessness. So these are the important clinical features of compartment syndrome. As you can see from this picture, whenever you suspect compartment syndrome, so it's not like just because the patient doesn't have pulselessness or doesn't have poikilotherm or pallor, so you should not wait for long time. You should immediately go for fasciotomy, where you will make incision at the level of skin and also you will open the fascia. This is your muscle, so the muscle should bulge out. Okay, that's how your proper fasciotomy is complete. So muscle is bulged out. This indicates your fasciotomy is proper, right? Next. So the next one is Cowden syndrome. Again, it's a you will be knowing about this in case of pathology. So what are the main things that are present means usually you have multiple hamartomas wherever you have got this skin and also there will be macrocephaly. Mainly regarding surgery, you can remember one is thyroid cancer, there can be breast cancer, and also there will be even renal cell cancer. Okay, so renal cell cancer, thyroid cancer, breast cancer, and usually you can have even testicular lipomatosis also. Then the other thing is you can have even GI aorta matus also. Okay, this is about Cowden syndrome. Next, Crush syndrome. Again, it is a very important topic. So let's say for example, there has been some collapse of the building also, and some heavy part has been fallen on one limb. Okay, so what happens whenever there is huge weight that is there on the muscle? So whenever there is muscle compression or whenever there is huge muscle damage, so you know that whenever there is muscle damage, so there can be release of excessive myoglobin. Okay, so this myoglobin will come into circulation, so it will go to kidney, and this myoglobin will be excreted in urine. That is called myoglobinuria. Okay, because of this myoglobinuria or myoglobin coming into the kidney and call, it will cause AKI. So acute kidney injury. Why is this happening? Because of the increased myoglobin. Increased myoglobin, there is acute kidney injury. That is why again, whenever you encounter a case of Crush syndrome, usually it should be we should follow aggressive treatment and you should go for early fasciotomy within 8 to 12 hours. Okay, at least at the earliest possible, you have to go. Before you go for fasciotomy, you have to treat the patient very aggressively with IV fluids. Okay, then, so this is about Crush syndrome, right? Next, very important one, dumping syndrome. So it happens usually, that wherever you are removing the part of the stomach or you are doing gastrectomy, that it has got two types, Billroth 1 and Billroth 2. So again in Billroth 2, so wherever you are removing the part of the stomach and you will be anastomosing, like this is your afferent lobe. So this is your Billroth 2 operation. So whenever you have got this Billroth 2, there is more chance. So this dumping syndrome is more common with your Billroth 2. So whenever food comes very rapidly from stomach, because there is no pylorus here, the food enters very rapidly from the stomach into the small bowel. That is called your dumping syndrome. So, what are all the types of dumping syndrome? You have got two types. One is early dumping syndrome, late dumping syndrome. Usually, if it happens within half an hour or 40 minutes, usually there will be early dumping syndrome. So, what are all the clinical features? Again, it is something like a concept. So, just let us look at this. Let's say, for example, a patient has got Billroth 2 operation and he has eaten so much sugar or something like a very high carbohydrate meal. So, what happens whenever there is increased sugar and you have got anastomosis here like this? So, what happens whenever there is increased sugar? It will directly dump into your distal small bowel or that is your jejunum or something like that. So whenever this increased amount of sugar is coming here, you know that sugar is hypertonic. So excess amount of hypertonic sugar will be causing shift of water from your extra intestinal space into the lumen of the bowel. So there will be sudden rush of water into the intestinal lumen. Okay. So what happens? There can be increased sudden epigastric fullness will be there because of the distension of the small bowel, because of the shift of water, because of shift of water into bowel lumen. This is one important feature. Okay, right? Plus, along with epigastric fullness, you can have one will be bloating and even there can be nausea and vomiting. There can be nausea and vomiting, right? This is about early dumping. Let's say, for example, the same scenario, like you have got a Billroth 2 after operation. Now, let's say, for example, he has taken around 200 grams of sugar. Just for example, I'm telling you. Let's say, for example, he has taken some amount of sugar. So, whenever your sugar is there within the body, you know that there will be signal to your brain, and your pancreas will release whatever the amount of sugar, insulin that is suitable for your amount of sugar present in. Let's say, for example, let's consider this is your A, and for the A amount of sugar, your pancreas is releasing B amount of insulin. Okay. Now, as there is no pylorus, your 200 grams of sugar or A amount of sugar is swiftly coming from stomach into the small bowel. So already for this amount of A amount of sugar, your body has already released B amount of insulin. But because there is large amount, only small amount of food, let's say for example, around some part of your A has been absorbed, whereas rest of the sugar is still in the bowel lumen. Okay. So whenever you have got only small amount of sugar absorbed, but there is large amount of insulin present, so there will be rebound hypoglycemia because of the increased insulin levels. What happens? Rebound hypoglycemia. This is your late dumping, right? This is your early dumping. Okay, right? So as you can see, usually whenever you eat, especially carbohydrate rich wet, that means with more amount of water. Whenever patient takes more amount of water, it will cause certain clinical features. So you can remember like there will be two types of symptoms. One is GI symptoms. Then the second one will be vasomotor symptoms. This is second type of symptom. Okay, right? So as you can see here, you have sometimes diarrhea, you have got epigastric fullness, sweating again because of the sympathetic stimulation. Okay, that is your vasomotor symptom. Whereas in case of late dumping syndrome, you can have either tremor, sometimes faintness, etc. Okay, this is about dumping syndrome. So you need to remember it is more common after Billroth 2, right? Then, what will you suggest to the patient after a Billroth operation to avoid, to prevent this dumping syndrome? So, you should always ask the patient to take small and frequent meals. He should not take large amount of meals at a time. Okay. Then he should avoid obviously large amount of meal. And also, then you should ask the patient to take more amount of protein, more amount of proteinaceous meal. Then you should ask the patient to take complex carbohydrates so that there will be more time for it to break down. Okay, complex carbohydrates. Then you should ask the patient to avoid taking sugar rich drinks or more of a sweet kind of a things, sugar rich drinks. Also, you should always ask the patient to take small amount of the frequent meals with the liquid should be taken with meals. So you should not take too much amount of liquid with meals. Okay. So just take only small amount of water. After some time you can take water, but along with meals you should always avoid liquid with meals. Then you should always ask the patient to take. You should always ask the patient to avoid taking refined sugar. Okay, right? So these are some advices. So which should be done and which should not be done, right? Coming to the next one, which is an important one again. This happens after post-operative parotidectomy, especially superficial parotidectomy. Okay, post-op parotidectomy. This syndrome is called Fraze syndrome, which is also called gustatory sweating syndrome. What do you mean by gustatory sweating syndrome? So whenever patient takes food, patient is having sweating at a parotid area or cheek area. Okay, why is this happening? So to understand this, you should understand the nerve supply of parotid. So you have got obviously sympathetic system and parasympathetic system, and main parasympathetic system is your glossopharyngeal nerve. Okay, so ninth cranial nerve. So at the level of your otic ganglia, sorry, it's not otic ganglia. So after the relay of your ganglion, there will be post ganglionic fibers that are carried, and you know that sensory supply is there from your mandibular nerve. Okay, so usually this auriculotemporal nerve is the main thing which is carrying the post ganglionic fibers, and the sympathetic is by usually your T1 spinal segment. Okay, right? So what happens in case of gustatory syndrome or gustatory sweating syndrome, nothing but your Fraze syndrome, is that normally the area over the parotid bed, the skin wherever, let's say for example, this is your parotid bed and you have got skin here. Okay, so this skin has got a sweat glands, and you know that normally the function of parotid gland is saliva secretion. So that will be the stimulation for that saliva secretion is your parasympathetic. So this will cause the stimulus to release the saliva. Okay, so whenever there is, when the gap between parotid bed and skin is very minimal, there can be faulty regeneration of nerve fiber. So here it is normal, where parasympathetic fibers are supplying to the parotid gland and sympathetic is both supplying to the sweat gland and the parotid, but there is no miscommunication or there is no faulty innervation. But here, as you can look here, this parasympathetic fiber, this black color fibers, is going to the sweat glands over the parotid area skin, where you can have faulty reinnervation because of the faulty reinnervation. So because of this faulty reinnervation, what happens? Let's say for example, whenever patient takes food, this parasympathetic system will stimulate the parotid bed to release saliva. But the problem is, whenever you are having this parasympathetic stimulation, the stimulus is also going to the sweat glands over that parotid bed area. That is why there is increased sweating over the increased sweating over the skin over the parotid region. Okay.